Our next speaker is Dr. Kang from the City of Hope, who will be presenting patient-reported cognitive impairment in women participating in the RxPONDER trial, SWOG S1007, by menopausal status.
Thank you to the conference organizers, and on behalf of the responder investigators and my co-authors, it's a privilege to present patient-reported cognitive impairment in women participating in the responder trial by menopausal status. Here are my disclosures. Breast cancer treatment is associated with cancer-related cognitive impairment, and the effect of endocrine therapy versus chemotherapy followed by endocrine therapy, which I will refer to as chemoendocrine therapy, on cognitive impairment is poorly understood. Furthermore, whether menopausal status affects this symptom is also unknown. In the responder trial, women with early-stage hormone receptor positive, HER2-negative breast cancer with 1 to 3 positive lymph nodes and an oncotype recurrence score of 0 to 25 were enrolled. Approximately 5,000 patients were randomized to chemoendocrine therapy versus endocrine therapy alone. And in a subset of patients, a patient-reported outcomes sub-study was performed with health-related quality of life questionnaires given at baseline, 6 months, 12 months, and 36 months after randomization. A total of 568 participants were in this sub-study, 274 in the chemoendocrine therapy arm and 294 in the endocrine therapy alone arm. Our PRO sub-study was performed in the US and invited consecutive English-speaking patients from the time of study opening in February 2011 until the accrual goal of 500 patients was met in December of 2012. As mentioned previously, health-related quality of life questionnaires were performed at the listed time points. The questionnaires included a PROMIS Cognitive Function Concerns questionnaire, which will be the focus of my presentation, as well as the PROMIS Anxiety and Fatigue short forms and EQ-5D, a measure of global health. Our primary endpoint was mean cognitive function score by treatment arm and menopausal status. T-scores were calculated based on a reference population with a mean score of 50 and a standard deviation of 10. A higher score on this scale correlated to better cognitive function. We defined a change of 3 units as clinically meaningful. Our analysis was performed as intent to treat, and a generalized estimating equations model was fit to the 3 follow-up time points, adjusting for baseline score, treatment arm, and time point. We also calculated change from baseline score for the follow-up time points, as well as odds of clinically meaningful worse cognitive function. Here is the PROMIS Cognitive Function Concerns questionnaire for reference. This was an 8-item questionnaire regarding cognitive function with responses on a 5-point Likert scale. I'll now review the baseline characteristics of the participants. In the premenopausal group, there were 139 participants, 65 in the chemoendocrine therapy arm and 74 in the endocrine therapy arm. We see with the race and ethnicity data that this population was primarily white and primarily non-Hispanic. In the postmenopausal group, there were 429 participants, 209 in the chemoendocrine therapy arm and 220 in the endocrine therapy alone arm. Again, race and ethnic data show a primarily white and primarily non-Hispanic population. Here are our results. The mean cognitive function score with 95% confidence intervals are shown here at the study time points. In the premenopausal group, we see that the baseline mean cognitive function score is similar between the treatment arms. With chemoendocrine therapy, the mean scores decrease at 6 and 12 months and improve at 36 months, but not to baseline. In the endocrine therapy arm, the mean score decreases at 6 and 12 months, but to a lesser magnitude than chemoendocrine therapy, and improves to baseline by 36 months. In the postmenopausal group, baseline scores are again similar between the two treatment arms, and in the chemoendocrine therapy arm, again we see a decline in score at 6 and 12 months, with an increase but not to baseline by 36 months. Interestingly, in the endocrine therapy arm, the mean score stays essentially stable at the study follow-up time points. This table shows the mean cognitive function scores at the various time points by treatment arm, as well as a longitudinal mean score, which was calculated, a longitudinal mean score difference. In the premenopausal group, this score difference was -3, a clinically meaningful difference with a p-value of 0.01. In the postmenopausal group, the mean score difference between chemoendocrine therapy and endocrine therapy alone was -2.36, which did not meet the defined criteria for clinically meaningful difference, but was statistically significant with a p-value of less than 0.003. Looking at the data a little differently, we look at change from baseline score by treatment arm at the follow-up time points. We see here that a significant proportion of patients, we defined clinically meaningful as a change in cognitive function score of 3 points from baseline, and categorized scores with a decrease in score of 3 units or more as worse, an increase in score of 3 units or better or more as better, and anything in between was categorized as the same. In the premenopausal group, we see that a significant proportion of patients at each follow-up time point were reporting worse cognitive function score. Even out to 36 months, 42% of responders in the chemoendocrine therapy arm and 28% in the endocrine therapy alone arm reported worse cognitive function. However, clearly this response is not universal, as the majority of patients at the follow-up time points report same or better cognitive function. Findings are similar in the postmenopausal group, with a significant proportion of patients reporting worse cognitive function throughout the time points, with 41% in the chemoendocrine therapy arm and 36% in the endocrine therapy alone arm reporting worse cognitive function at 36 months. And finally, we calculated the odds of having worse cognitive function at each of the time points by menopausal status. Here we see that the odds of worse cognitive function are higher with chemoendocrine therapy, or numerically higher with chemoendocrine therapy at each time point. And in the postmenopausal group, at 6 and 12 months, the confidence interval does not cross 1. In summary, we find that the chemoendocrine therapy has a greater negative effect on cancer-related cognitive impairment compared to endocrine therapy alone in both pre- and postmenopausal women. Cancer-related cognitive impairment seems to persist over time in a significant proportion of patients, and I would like to mention that these findings differ slightly from an analysis of cognitive impairment in participants of the TAILOR-X trial. In the TAILOR-X trial, they found that chemoendocrine therapy resulted in worse cognitive impairment at 6 and 12 months, but that these differences between chemoendocrine therapy and endocrine therapy alone vanished by 12 months and with longer follow-up. The TAILOR-X trial did use a different cognitive function scale, the FACT-COG, and these differences in findings cement the need for further study of this important side effect. Limitations of our study include a small sample size, particularly in the premenopausal group, participant dropout over time, the lack of adherence data to endocrine therapy, and unknown menopausal status changes during follow-up. Our study highlights the need for future investigation of cancer-related cognitive impairment in a more diverse population, as well as understanding who will develop cognitive impairment and who will recover. I encourage you to check out our poster session of an anxiety and fatigue PRO analysis authored by my co-author Michelle Locke. This will be at poster session 6 on Friday, and we plan a forthcoming analysis on interactions between anxiety, fatigue, cognitive impairment, and quality of life. I'd like to acknowledge the participants and their support systems, as well as the entities listed here. Thank you once again.
Thank you, Dr. Kang. We will now take questions from the audience. As people are coming to the microphones, I'll ask a question. Were you able to look at whether or not the type of chemotherapy that people received may have impacted on the cognitive changes?
That's a great question, Dr. Patridge. We do plan to look at this in the manuscript, but we do not have that data yet.
Looks like, wait for somebody, I think Hope's going to the microphone. Yes, she is. Microphone 3.
Hi, Hope Rugo at University of California, San Francisco. Beautiful talk and excellent and important research. I'm curious about, in patients who receive chemotherapy, because of all our pre-meds, they end up having insomnia and maybe, we've seen more depression. Could cog meds have played a role in this, such as sleep aids, CBD, all sorts of things that we give for patients that they continue often after treatment?
That's a fascinating hypothesis, Dr. Rugo. We don't have the full cadre of symptoms that patients experienced on chemotherapy, but we certainly will look at any data we do have for the forthcoming analysis.
Microphone 4.
Matteo Lambertini from the University of Genova. Thank you very much. Very important presentation. I have a question on the type of endocrine therapy in premenopausal women. Do you know how many receive OFS as part of adjuvant endocrine therapy?
Great question, Dr. Lambertini. Our rates of ovarian function suppression in the premenopausal group are similar to the responder trial overall. It was a very low percentage, close to 15% in the endocrine therapy arm.
So a question from the virtual audience. Is there a better way to evaluate cognitive impairment than a self-reported cognitive impairment? And they also want to assess whether or not anxiety with diagnosis and treatment may be playing into this as well.
So those two questions. I don't know of a better way to assess cognitive impairment, but certainly it does open up the need for more accurate assessment because we are finding slight differences depending on the tool used. And then to the question about, oh goodness, I'm blanking. The question about...
Oh, it was about anxiety.
Anxiety and fatigue, yeah. So we are planning to look at the relationship between the different reported symptoms and kind of their effects on one another.
Thank you. Microphone 3.
Thompson from Germany. Just one question. So I was missing a control group. So patients who have had an operation on DCIS or anything else where you have not done any treatment, because you could imagine that you would have changes over time in every woman or also man, of course. And the second point is PROMIS seems to be a quite multivariable instrument and tool, and you're measuring a lot of items. However, I'm missing other types of cognition measurement like spatial recognition, spatial navigation, and such things that might be differentially regulated in endocrine treated and non-endocrine treated patients.
Yes, so to the second piece of your question, I completely agree. This was a limited tool, patient-reported outcomes within only an 8-item questionnaire, but it allowed us to get data from a significant number of patients. Kind of previous, as was mentioned previously too, I think there's not a perfect measure of cognitive function, at least that I'm aware of in the clinical trial space. I think perhaps more formal testing in a different study would be warranted.
And microphone 5.
Yes, thank you, Cindy Osborne, Dallas, Texas. But just such an important topic, and I really liked your talk. But I'm wondering how much, and I know that you said there's another presentation going to discuss sort of anxiety and depression, but how much that diagnosis, being told you have breast cancer, undergoing chemo, or even endocrine therapy, surgeries, radiation, how much that sort of colors their interpretation of their cognitive function.
Thank you, Cindy. I do encourage you to check out our poster on anxiety and fatigue patient-reported outcomes this Friday. But I do think we have more work to do in terms of the interplay of these symptoms on one another.
I think that's all the time we have for questions. Thank you again, Dr. Kang, for your wonderful presentation.